So today we're going to talk about telehealth. I know for the health and hospital folks, it can be a little bit different. Some systems are integrated, some aren't. But we're going to speak pretty generally to include physician practices as well. We're going to speak generally in terms of what telehealth is, but where we can, we'll build in how Michigan telehealth works and some Illinois, because we're both in Chicago and it's easy. So just an overview of what I'm going to talk about. I'm going to talk about the requirements to create that relationship with between the provider and the patient, what the standards are for non-physicians, which I think is an important aspect that often gets overlooked. Some of the other requirements, some states have some interesting requirements. And then we're going to talk about remote prescribing. So what is telehealth? And I promise this is the only time I'm really going to read from the slide. But these are, and I don't know if you can read them, but these are the definitions. One thing that both Michigan and Illinois do that most states do is they wrap up telemedicine within the definition of telehealth. So Michigan, it's a much broader definition of what telehealth is. It's the use of electronic information and telecommunications technologies to support or promote long-distance clinical health care, patient and professional health-related education, public health, or health administration. And then it says it may include telemedicine. And that definition is next. So the definition of telemedicine is the use of electronic media to link patients with healthcare professionals. I think that's important. It doesn't say physicians, it says healthcare professionals in different locations. And that's another piece. Some states will, or at least they used to, require that patients be within a certain area, whether that was in a rural area or whether it was within a hospital. States generally are going away from that. Medicare and Medicaid are a little slower, but the states generally don't define telehealth or telemedicine in terms of specific locations anymore. Sorry, and then the next part is really important as well for Michigan. The definition of telemedicine says that it's going to involve real-time interactive audio or visual or both telecommunications systems, and the patient must be able to interact with the off-site healthcare professional at the time the services are provided. So this is talking about establishing the relationship. I'm talking about it now because we're going to talk about it probably 6 or 7 more times. In Illinois, it's a little bit different. The definition of telehealth is really what I would expect to be in telemedicine. It's talking about evaluation, diagnosis, and interpretation of electronic information that's transmitted to a licensed healthcare professional. So a difference that I want to point out is in Michigan, it is a little broader. So you're going to have more things that are deemed telehealth. And as the laws build and grow, that distinction may be important from a payer perspective, and I'll let Monica talk about payments in the second half. But in terms of, are you being paid for quote unquote telehealth? Does it matter that what you're doing is telehealth or telemedicine? A lot of times it matters from a payment perspective. So that's something to think about in the future. And then just going down to the bottom, the definition of telemedicine in Illinois, it specifically references the Illinois Medical Practice Act. So telemedicine is very much tied to being a physician or a delegation of the authority that's granted to a physician. Rendering written or oral opinions concerning diagnosis or treatment. So those are kind of the key pieces of those definitions. And I promise it will not be that boring for the rest, or I'll try not. So now we're going to talk about scope of practice. Scope of practice generally, not in terms of telehealth, but scope of practice generally, it's talking about what can a licensee do. An RN or an LPN is going to have a different scope of practice from a physician. And states are going to differ a little bit when you talk about NPRNs and PAs. That's a big push right now, is to give them more individual autonomy and prescribing authority. But in a lot of states, you still have a flow down from the physician of that authority. You have to be tied to a physician for that kind of authority. So understanding what an individual can do on their own is important before you start a telehealth practice, because if they can do it in person, they can do it via telemedicine most of the time. Obviously there are more restrictions, but don't think of telehealth or telemedicine as a totally separate practice. It's just taking that same practice and then doing it through secure internet transactions. Another thing to think about at the very bottom are the telehealth or telebehavioral health professions, psychology, social workers, therapists. I think that this is probably, and Monica, you can have your opinion on this as well, but I think this is probably the biggest expansion in terms of the number of new practices or new apps that are being developed in any space under telehealth or telemedicine is within telebehavioral health. So now we talk about establishing the relationship. Generally speaking, what you're doing matters in terms of whether you have a relationship to do it. So if you're prescribing, a Schedule II controlled substance, there's going to be a different level of scrutiny, a different sometimes a different list of things that you need to do in order to establish that relationship. And then you have added levels of scrutiny for doing that via telehealth. If you're setting up a telehealth practice where you're just providing information, you're not prescribing, you're not diagnosing or treating, then you may not even fall under that state's definition of telehealth. So this may not even actually matter. So knowing what you're going to do through telehealth is very important. Don't just jump into the game and say, we're going to have Skype and we'll tell people they can Skype in and we'll treat them however you want. You really have to be thoughtful before you implement whatever your product is going to be. So in terms of establishing that relationship, we talk a lot about the physician-patient relationship, but I want you to think also about the provider-patient relationship. Depending on the state, you can do a lot with physician assistants or nurse practitioners or even RNs in terms of providing direct care through telehealth or telemedicine. Traditionally, as I alluded to before, there were a lot more restrictions. A lot of states required an initial in-person encounter before you could create that relationship to allow you to treat the patient via telehealth thereafter. It's a little silly, I think, because the whole point of telehealth is that you don't have to come into the office. So nearly every state, there's still one state that technically doesn't allow you to create that relationship via telehealth only or telecommunications, but every other state allows you to create that relationship through some modality, and we're going to talk about what that term means in a little bit. In Michigan, I only bring up this first bullet, it should have been the second bullet, but in Michigan, like most states, you have to have consent from the patient to use telehealth to treat them. But there is an exception, and I'm from Jackson, Michigan, so everybody thinks of the prison, which is just the best thing for people to think of. Oh, you're from Jackson. How's that prison going? I have no idea. But in terms of consent, if you are under the jurisdiction of the Department of Corrections, your consent doesn't matter. You're a ward of the state, and that's actually, I bring it up because actually we see a lot of programs being implemented to save money by using telehealth for those services. And there are some risk factors that, it can be very, not just lucrative, but for safety reasons, it can be a good idea to use telehealth in those situations. But going to the second bullet, we talked about it already, but in order to create the relationship in Michigan, you have to use real-time interactive audio and audio or video, or both telecommunications systems, and the patient has to be able to interact with the provider. In Illinois, it's different. In order to establish that initial relationship, basically you're following the standard of care that you would follow otherwise. So in that perspective, you have to think about what is it that you're doing. If you're just talking about, do you have a cold? Probably. Are you going to prescribe anything? No. Well, then you probably don't need a lot to establish that relationship, to have that interaction. If you're going to, as I said before, if you're going to prescribe something like a controlled substance, and I know there are a lot of limitations on that we'll discuss, but if you're going to prescribe something, then you're probably going to need something else. But Illinois is one of a number of states that goes on what I call the standard of care model or modality. If your standard of care is a questionnaire that they fill out and say, well, I think my blood pressure is 90 over whatever, that's not going to cut it for a lot of things that you can do as a physician. Sorry. One note here at the bottom, there are a couple of kind of exceptions to think about in terms of your model and where you may be able to loosen the restrictions on your SOPs on how you can deliver certain kinds of care. Second opinions and consultations. If you're not treating a patient, then you probably don't have to have all the same safety mechanisms for establishing a relationship, because you're not establishing a relationship with the patient. I know it seems a little obvious, but you'd be surprised how often it comes up where you're so entrenched in, I've got to follow all of these rules, and then you forget, oh, all right, well, it's all about treatment. If I'm not treating, I guess I don't have to worry about these. And in terms of existing patients, if you have an intrastate telehealth practice, maybe an add-on to a physician practice, if you've already seen them, last week, you don't have to go through XYZ in order to establish the relationship with that patient for the same treatment and diagnosis. If you're doing a follow-up visit via telehealth, you've already established the relationship with that in-person visit. Most of the time. I have to put the asterisk there because I'm an attorney and I don't want you to go back and say, well, I thought everything was fine and then I got sued. So modality, I've used the word a number of times, but now I'll give you kind of the idea of what that is. The two main modalities, and I know this is not the term of terms. We as attorneys use a number of different terms to talk about kind of the same issue. I've seen a number of different presentations where they do a really great job talking about it as something else, but in the firm, for whatever reason, we say modality. So here I am. Real-time or synchronous, which is a term that you see a lot, synchronous, is usually talking about live two-way video conferencing. Obviously, you're going to use a system that's HIPAA compliant, but that's the idea with synchronous. But synchronous can also be a telephone call, or it could be, a Skype without audio, again, with HIPAA built in. But it can also be audio only, although I don't see how that would really work, even though technically under some state laws it would be permitted. And then when we talk about asynchronous, we're talking mostly about store and forward. So you're sending your medical records through a secure portal. And those are good to differentiate because you're going to see those terms a lot in a number of different state laws and regulations. But it's also it's good to understand that, like in a state like Michigan, where you really have a synchronous requirement, the modality is real-time audio or visual or both telecommunications, and the patient has to be able to interact at the time that you're providing it. That doesn't mean you can't use store and forward. It doesn't mean you can't send patient records via a secure portal or pictures. Let's say you're a dermatologist. It doesn't mean they can't send pictures of what's ailing them and provide it to you. It just means it's not enough to establish the relationship. And once you've established the relationship, the door opens up as to what you can receive in order to treat that patient, what information you can utilize. I know I mentioned it earlier, but it's something that comes up even now, even though we've got laws on the books that say in most states that you can't do it, people still do it. I would almost never recommend trying to establish a relationship with a patient by questionnaire only. If there are other pieces to it, if you've already seen that patient in person, okay, but if you're going to put an internet site out there and say, hey, do you want this drug? Do you want me to prescribe you this drug? Fill out this form and I'll send it to you. And I guarantee you might be able to do it for a while, but you're not going to do it forever before you get sued or your license is taken away. So questionnaire only, if you're approached by a company that says, hey, we want to do questionnaire only, be very skeptical. I know that Monica is going to talk about licensure a lot, so she's going to get into Federation of State Medical Boards, but it's an organization that provides a lot of information that's really good, and they have their own model policies. I think you should read them. I think that they're good policies. They are not state law, so don't mix them up. But it's a good way to understand how other states may be doing it as well, because I would say the majority of telehealth is interstate. So you're not just dealing with patients in Michigan, you're dealing with patients outside of Michigan. For a hospital network, that may not be true, but for a physician practice or for a lot of startups that we see, they're interested in patients in other states. And when that happens, you're going to have to abide by the laws of the state where the provider is as well as where the patient is. So if you want to perform dermatology in California because the sun is up a lot more than in Michigan, then you're going to have to abide by those state laws, including some corporate practice laws that we're not going to cover today, but just understand there's a lot more than just what's in the state of the provider. So consent is a part of every state's telehealth laws at some point, somewhere. In some states, they have consent requirements everywhere. So you can have separate consent requirements to establish the relationship, separate consent requirements to treat, separate consent requirements to treat via telehealth, even though it seems obvious you already have to have consent to treat, and separate consent requirements to treat with certain products. In Michigan, consent for treatment is under Michigan Comprehensive Law 333.16284. But when you're, as I said, when you're dealing with other states, you need to know what you need to consent for. And a good idea, if you know that you're going to go into several states, pick the bottom. Find out, where do they require consent, and then make one form that covers everything. It's usually not a problem. Sorry, and one last point, document your consent. It's not enough to just have the form. It should, even if it's not mandated by law, it's a good idea to include it in the patient's medical records and to provide that consent to their primary care physician as well in most cases. And that's going to be part of the consent. In some states, that's actually required. In other states, it's more of a gray area. So the next slide goes into referral obligations, and these are issues that not every state has. States differ quite a bit in terms of telehealth and what they require, but in terms of referral obligations, you see it a couple of ways. One, there's an obligation if you can't do it via telehealth. Obviously, you can't perform open heart surgery via telehealth. You can actually counsel someone. You can help if you're a thoracic cardiologist and you're porting into a screen in an OR. You actually can help. But in terms of making the incision, you can't do it today. So that's a ridiculous example, but if a patient said, hey, I want you to do this, you'd have to refer them in some states. In other states, there isn't that obligation, but in Michigan, there is an obligation if you're prescribing a drug via telehealth that you provide the patient with a referral for other healthcare services that are geographically accessible to the patient, including but not limited to emergency services. And that's important to understand because if you're treating a patient in California, you may not know what's available in California, so that needs to be built into your program. Follow-up obligations are very similar as well. That if you can't do the follow-up via telehealth, in a lot of states, you have a requirement to find a local practice that can perform that follow-up. And in Michigan, if you're providing prescription drugs, I'm confusing the new laws on controlled substances. I was just reviewing them this morning, and there is an obligation for controlled substances that you provide very stringent follow-up, and we'll actually talk about that in a few slides. Other states have some interesting laws. Texas. This isn't about follow-up or referral. This is just weird things that you need to know. In Texas, if you're providing telehealth, you also have to provide patients with information on how to file a complaint about you and your provision of telehealth to the Texas Board of Medicine, and that has to be very accessible. I would actually recommend it's part of the consent. Just give them the information. And Indiana similarly says you have to sign a waiver so that if you do anything wrong and you get sued, it will be in an Indiana court under Indiana law. So those are fun. And now I want to talk a little bit, even though I've already kind of talked about it, but talking about other licensees using telehealth. There's more than just scope of practice. So scope of practice is obviously very important. If they're not legally able to do it, then you shouldn't allow them to do it via telehealth. But there are also telehealth laws that are specific to psychologists or psychiatrists or family therapists. It's interesting. Some states have the same law, but they have it 10 times for 10 different licensees, and sometimes it's a little bit different. So before you establish a program, make sure that you're looking at every board that's involved to see if they have rules or recommendations or a program for telehealth. Whoops. And the last thing at the bottom is just to understand that sometimes they don't, the licensee doesn't have the ability to do something within their scope of practice, and so you're relying on delegation, whether that's a standing order or something else. If it's an NP, then you're going to have an agreement with them or a PA. But understand that if you're establishing that for Michigan, and I know I'm beating this drum, but the way that you establish it in Michigan may not be okay in North Carolina or in Florida. So you have to review those laws for delegation as well as their scope of practice. And now we get into the fun stuff of remote prescribing. In order to prescribe drugs, in most states, there is another level of creating that relationship. Or if the state bar, like in Michigan, is already high, the modality is that you have to have audio or visual, and it's got to be synchronous, then there may not be an additional step that you have to take. But for example, Delaware says that you can have a telehealth relationship, but you can't prescribe any drugs via that relationship. They're the only one, and hopefully they change pretty soon. But that's pretty interesting. Even under federal law, you can prescribe drugs, but controlled substances are another story, and we'll get to that in the next page. In New Jersey, like a lot of states, and I think Illinois as well, you have to have an appropriate physical exam. Now, what does that mean? Can you do it via telehealth? That's really a question for the physician. If the physician feels that they can do it, if it's within the standard of care, then yeah, you can. If it's something that you can't perform with the technology that's currently available, then no, you can't, or it's inappropriate. And that's something that boards of medicine will have more of a say in than legislatures in those states. In Maryland, Maryland has a lower bar for that initial patient relationship, but they require the physician to incorporate real-time auditory communications or real-time visual and auditory communications if the relationship that's already been established didn't include an in-person face-to-face interaction with the patient. So that's an example of where the bar is higher in order to prescribe drugs via telehealth. And in Michigan, I'll just read it. It states that a healthcare professional who is providing a telehealth service to a patient may prescribe the patient a drug if the health professional is a prescriber who's acting within the scope of his or her practice in prescribing the drug. And that makes sense because they've already had a pretty high bar in order to establish a relationship to treat. So some of the issues with remote prescribing that vary across state lines, as most of this does, are treatment plans is one issue. So if a patient already has a treatment plan in place and you are treating them for the same condition, if you adhere, you may be required to adhere to that treatment plan, or if you deviate, you have to contact their primary care physician and let them know that you are changing the treatment plan. And if it's for a new diagnosis, you may have to create a treatment plan under that state's law. Follow-up, we've talked about. Consent, we've talked about, but I have it here so I can harp on it so that you understand that there are several instances where there's a triggering event for consent. And then there are some states, not that many, but some states that have laws that are specific to patient groups, and Illinois has one. You can't treat a patient who has a quote-unquote debilitating medical condition, and I didn't include the definition, but you can't treat them remotely via telemedicine, and that's more of just a beware that there may be particular patient groups that by law you can't treat. And now the fun stuff. So I've harped on, you can go on my blog or profile, and I know Nathan Lackman has said all the same things. We're complaining quite a bit about the DEA because 10 years ago the Ryan-Haidt Act was passed, and the Ryan-Haidt was really about shutting down online pharmacies that were issuing drugs where you're just filling out a form and say, yeah, I would like some Vicodin. Here, sure, I have these ailments. Send the form, and then you get it through the mail. So that was the purpose, but what it did, before the technology was really available, what it did was make it almost impossible to prescribe controlled substances via telehealth. There are exceptions, but the whole idea behind Ryan-Haidt is that you have to have an in-person visit before you can prescribe controlled substances via telehealth. And there are some exceptions. Some of the exceptions are a little silly, like if the patient's already in a hospital, well, if they're in a hospital, why can't somebody there just prescribe it? But there are, I think there's one for, treatment by an Indian tribe. So there aren't a lot that are very usable for most people, most practices. There is, however, this special registration that will allow you to prescribe remotely as long as you apply for and are granted a special registration. The problem is that 10 years ago, the DEA was supposed to promulgate rules to tell us how to get one of those, and they haven't. So today, obviously, the opioid crisis, we have just a litany of litigation pending in Congress, and a lot is going to be passed. But every congressman wants to get their name on one of these bills to show their constituents that we care and we're doing something about this. And so you've got a lot of bills that are kind of all over the place, handling the same issue in a couple of different ways. So I don't want to go into what the future will be, other than I can almost guarantee that this will be addressed. I won't say taken care of, because I don't know if they're going to give DEA 6 months to put together rules and DEA just says we don't care again. But this is something that you're going to have to watch out for in the future. And speaking of controlled substances, I know that Michigan has recently passed controlled substance laws. There is one law that I want to talk about and then tell you don't worry about it right away. And that is the bona fide prescriber rule, which was supposed to be in effect now, but was delayed until March 31st of next year, or earlier if they promulgate rules. I believe the Board of Medicine has the obligation to promulgate those rules. But essentially, if you are treating via telehealth, you have to be a bona fide prescriber in order to prescribe controlled substances. And actually it applies to everyone, but thinking in terms of telehealth, what does that mean? It means that you have to review the relevant medical records and quote unquote relevant medical evaluation of the patient conducted in person or via telehealth. And it's the same definition of telehealth that we already have. Other states are going to have other limitations. I promise this is my last slide. Other states have other limitations. Some of them are just on acute pain management in general. You can't treat acute pain through telehealth. Some will not allow you to prescribe an abortion-inducing drug. That doesn't mean necessarily that it's a drug that's supposed to create an abortion event, but if it has that side effect, then you may be very limited, and that's something to be aware of. And then they're going to. There are states where specific classes of drugs are limited. You don't have that in Michigan, though. Michigan is pretty wide open. However, in most states, you have this catch-all that says, yeah, you can prescribe as long as it's quote-unquote in accordance with federal law. Well, the Ryan-Hyde Act is still on the books, so that's a federal law that says that you can't do it. So I don't advocate that you go out there and say, well, I can do it under Michigan law, and I'm just going to rely on that. And just if you weren't aware, NPs and PAs often can also write these prescriptions. So just make sure that they have that authority to do so via telehealth as well. All right, thank you very much.
Hi, welcome. Again, my name is Monica Chmielewski. I am a partner in Foley and Lardner's Chicago office, but I want to thank you for giving me the opportunity to come and speak with you today. I'm actually born and raised in Michigan, and it's always nice to come home and mix work with seeing family, so thank you for this. So you've heard a lot of legal considerations regarding telehealth, telemedicine, and you get to hear some more, so this will be fun. But before we really get into all of that, all right, here we go. Why are we here? Why do you care about this? Telemedicine, the practice of providing services remotely using this technology, is increasing at a very quick pace. Providers and patients alike are embracing it. They want to use technology to receive services. I mean, think about it. We live in an age where a patient, I want something in my hands at the touch of a finger with the technology that we have. I mean, I'm going to date myself, but I remember the first cell phone I had was one you plugged into your car and was in a bag. Now my cell phone can track, my heart rate. It provides all this medical information. With this adoption of telemedicine, we are seeing providers seek to adopt it despite the legal challenges that are out there. Challenges like, Brad was talking about, licensure, which I'll talk about, reimbursement. Providers are adopting this because they're seeing this as a way where they can increase access to patient care. They can increase the quality of patient care. and to be honest, also increase their market share. I mean, really in the end, sometimes, unfortunately, it's about the bottom line. The hope is that as providers continue to adopt and embrace telemedicine and implement it, and as patients continue to demand its use, the hope is that that's going to help address some of the challenges that you're facing. Challenges in the field of reimbursement. As telemedicine is adopted, the hope is that maybe providers will then push payers, to further expand coverage for telemedicine services. The hope is that providers implementing this will cause regulatory agencies to perhaps lessen some of the regulatory hurdles that you face with telemedicine, such as licensure barriers, and again, reimbursement. Now, as I mentioned, telemedicine is being adopted quickly. Foley's actually conducted telemedicine surveys. We conducted one in 2014, and again, most recently in 2017. And what we did, it's actually been very interesting. We surveyed over 100 senior executives at various hospitals, ancillary service providers, and similar entities, and asked them about how they're using telemedicine. What do you see as the obstacles? What do you see as the challenges? Now, it's actually in 2014, over 87% of our respondents said in 2017 they really don't anticipate using telemedicine much at all. And when that stat came out, I started thinking, okay, maybe I should rethink this area of law that I'm focused on right now. Thankfully, in our 2017 survey, what we've discovered is over 3/4 of the respondents say they have current active telemedicine programs. They're seeing patient demand for it. They are seeing provider buy-in. And of those 3/4, over 53% actually said, not only do we offer telemedicine programs, we're actively growing them. They are increasing our market share. They are being utilized, and we're going to continue to grow those programs. In terms of the growth of the programs and the opportunities, listed here are different opportunities that were identified. Leading the way are second opinions, or specialty opinions, mental health services. There's a lot of opportunities that providers see in those fields. Going all the way down to telestroke and telepsychiatry services. Some of the keys when looking at a telemedicine program is looking at the legal considerations, but also figuring out in your community, where is there a need? And I'll touch upon this a little bit more, but say you're in a community and you can have the ability to serve some of your rural outliers, and you're seeing that there are very poor stroke outcomes, and there's really very few providers that maybe are, stroke specialty providers. That could be the perfect reason to start implementing a telestroke program. So it's identifying the potential opportunities that are out there when you're also looking at the legal considerations. Now, again, legal considerations and obstacles. Again, we asked our respondents, what do you see as your major hurdles? Notably, reimbursement. And we're going to touch upon reimbursement and some of the limitations that are out there in terms of reimbursement. But again, as we noted, we're hoping, and there's been some policy changes that show that there is some movement to expand reimbursement. But reimbursement does remain a major, consideration, a major concern among providers that are implementing telemedicine programs. Physician buy-in was another reported obstacle. What's interesting is that's actually dropped in terms of significance. In our 2014 survey, that was a much bigger consideration, an obstacle that providers identified. Now, as that's dropped to only 32%, we're showing there is physician buy-in. Physicians are jumping on board and really want to have the ability to utilize telemedicine as a way to further reach patients. So what we're seeing, despite these current obstacles, we really are seeing the acceptance of telemedicine and people looking for ways to implement a telemedicine program despite some of these challenges. And the first challenge that I'm going to talk about, Bradley had discussed a number of legal factors, is licensing. Now, in general, the physician that is offering care via telemedicine is required to be licensed in the state in which the patient is physically located. Essentially, putting the patient at the originating site, where the patient is, the provider regardless of what state he or she is in, needs to adhere to the licensing rules of that state, which are mainly governed by each state's medical board. Michigan is no different. You require that any physician that's going to provide any type of healthcare services to a patient located in your state needs to be licensed in Michigan. So this is going to impact telemedicine programs for your border states. So when you think about Ohio or Indiana, if there are hospitals kind of on the crux of those, any physicians in those states or any state that wants to provide services needs to have a Michigan license. When you're thinking about a telemedicine program, if you're operating one in the state, that's easy. Your physicians are Michigan licensed. You can then provide care to patients licensed in Michigan. If you're a Michigan hospital on a border state and you want to implement a telemedicine program that perhaps reaches out to Indiana or into Ohio, you're going to need to look at their specific laws as well and determine, okay, do my physicians need to be licensed in Ohio and Indiana? There are some common exceptions to the licensure requirement, and I've listed out some of them here. Brad touched upon some of them. Exception for consultation, providing a consult to a peer. Follow-up care. A patient comes, sees you, you perform some type of a surgery on them, you need to provide follow-up care. Great way to do that, and a lot of programs are using video consults for follow-up care. That's one way to do it, and there are licensing exceptions for that. Think about using telemedicine as an example in a destination medicine type of program. The opportunity to use video monitoring and interactions for initial patient consults, starting to establish a relationship, having referrals come from other physicians. You can do workups, have that relationship, identify the patient, have the patient then come perhaps and travel to your health system, have a surgery performed, then go home, and have the follow-up care being provided by one of these means of telemedicine. There are lots of ways that you can actually embrace this for a successful program. Now, in terms of finding potential ways to overcome these licensing barriers, there is the Federation of State Medical Boards. It has introduced the Interstate Licensure Compact. Before I start talking about that, the federal government has recognized licensure as a potential barrier. There actually has been legislation that was introduced where the government was trying to address this issue, where they actually looked to redefine the originating site for licensure purposes to say that, okay, the originating site is really where the physician is. So when the physician provides care via telemedicine, he or she would need to be licensed in the state where they physically are. That would have overcome the licensing barriers. Unfortunately, none of that legislation has passed yet. The interstate, so the Federation of State Medical Boards has introduced the Interstate Medical Licensure Compact, and that's been adopted currently by about 1/3 of the states. And essentially what this is it offers an expedited pathway to licensure for qualified physicians. It's an agreement between 22 states and the 29 medical and osteopathic boards in those states. The licensed physician, if they're in one of these compact states, can qualify to practice medicine across state lines if they meet the certain eligibility requirements. Now, approximately 80% of the physicians do meet the eligibility requirements, and the application process is expedited because that physician's primary state of licensure, where he or she has submitted their original information, can take that information, they essentially re-verify it, they perform another background check, a current one, make sure the physician hasn't engaged in some felony between the time of licensure. It should have been reported anyway, and then they're able to provide them licensure in the compact. Once the physician actually has passed that, he or she can choose whatever state they want to practice in, so long as it is a state participating in this compact. Now, currently Michigan is not a participant in the compact. However, you have introduced legislation that would essentially serve to adopt it and make it into law. So you have House Bill 4066 and 4067, which are tied bills, so they both need to pass for this to be enacted into law. The House passed the bills in October of 2017, and then they've been referred to the Senate on Committee for Health Policy, where it's my understanding they currently sit. So if enacted, essentially what the bills would do would be to implement the compact, and you would be a participant in the compact. House Bill 4066 actually comprises 24 sections and is described as detailing an alternative licensing process for allopathic and osteopathic physicians that promises to speed up the licensing process. So this is positive for Michigan. If you can have those, if those bills get passed, you're actually going to be part of the compact, and then your physicians are going to have an ease for obtaining licensure to actually practice in telemedicine in conjunction with the other compact states. So things to consider as you're implementing a telemedicine program. Okay, so reimbursement. Sources of revenue in telemedicine. There's multiple. I mean, consider commercial health plans, Medicare, Medicaid reimbursement, self-pay. You can have contracts with between the institutions for payment for the services. There's employer self-paid health plans, cash pay. There's numerous sources of reimbursement. What people, despite the numerous sources, what people really focus on are Medicare. Medicare and Medicaid are the two main, and commercial payers, but we're going to start with Medicare and Medicaid. Medicare has numerous conditions for payment, and I've listed out 5 here. They don't seem too onerous, but they really do serve to, unfortunately, limit reimbursement. The first requirement is that the patient actually has to be in a qualifying rural area. So the patient at the originating site needs to be in either a county or an area that's outside of a metropolitan statistical area, or they need to be in a rural health professional shortage area. So that's requirement number 1. You have to make sure that you're in one of these rural areas. Now, if you meet that requirement, if the patient's in a HPSA or outside of a metropolitan statistical area, then they still need to be at one of the enumerated qualifying facilities. The 8 qualifying facilities under Medicare include hospitals, critical access hospitals, rural health clinics, FQHCs, SNFs, hospital-based or critical access hospital-based renal dialysis centers, and community mental health centers. Now, notably, none of those locations are the patient's home. So in order for a patient to receive services right now under telemedicine and have them be reimbursed by Medicare, they need to be in one of these locations. A lot of people argue that really defeats the purpose of telemedicine, because if they're at one of these locations, they're already at a healthcare facility. Then you say, okay, well, maybe the facility is a rural one, they don't have all the specialists, and that's where telemedicine comes in. But the government is really trying to work to get on board so that patient homes and they are included in an originating site, and we'll talk about that with the Bipartisan Act. So once you've determined, 1, they're in a rural area, 2, they're at one of the qualifying sites, the services then need to be provided by individuals that are determined to be or listed as eligible professionals. And that includes who you would think of as the usual suspects: hospitals, PAs, physicians, PAs, NPs, nurse midwives, clinical nurse specialists, so on and so forth. There's a list of the people that need to be, that qualify. Then, when you go on to condition number 4, think of it like a flow chart. You have to meet 1, then 2, then 3, and then you get down to 4. 4 is the means of the provision of the service. Right now, Medicare does not reimburse for asynchronous services, so store and forward. It has to be through real-time audiovisual. The exception to the lack of reimbursement for an asynchronous service is if you're participating in one of the telemedicine demonstration projects in Alaska or Hawaii. None of us are in Hawaii, unfortunately, so we are limited to right now synchronous reimbursement for synchronous technologies. And then finally, the service has to be one listed in the various codes that Medicare has actually issued that say that they will reimburse for. And you can find all the different codes on Medicare's website. They have entire books on this. Now, there have been, I apologize, so I'm going to speed up here. I'm looking at the time. Sorry. There have been policy changes and changes in 2018 for Medicare reimbursement. Right now, you're going to be using a place of service code 02 for reimbursement and no longer the GT modifier. Medicare is largely eliminating the use of the GT modifier. Historically, it was required. Either the GT or GQ modifier was required for claims. The GT basically signified synchronous services, with the GQ signifying asynchronous services. Now, it started in January 2018, the POS code needs to be used for all professional claims, and POS 02 indicates that the service is being provided by telemedicine. The GQ modifier is still used specifically with the Alaska and Hawaii demonstration projects. They've also introduced 7 new codes for 2018, which expands the services that they will provide reimbursement for. There's a new code for remote patient monitoring services. And then, unfortunately, another policy change is the OIG is now getting involved. They are seeing the expansion of telemedicine, they're seeing it being utilized, and so they've commenced projects to review telemedicine. The first project is looking at Medicare, the second one is looking at Medicaid. In the Medicare project, what they actually looked at and determined is they reviewed claims and they discovered that there were claims submitted by the distant site provider, but they didn't see the corresponding claims submitted by the originating site provider. And as you recall, for Medicare to reimburse for telemedicine services, the originating site needs to be one of those enumerated, facilities. It has to be, the patient needs to be an originating site in a rural location. If you don't meet all of those criteria, the reimbursement is not proper. And what the OIG found, I think I went one too far. Oh, I guess I did not, I'm sorry. What the OIG found was that Medicare paid out $3.7 million in inappropriate payments for telehealth services during the 2-year period. And they said that nearly 1/3 of the claims reviewed didn't meet the eligibility for reimbursement because the originating site must be a medical facility or a practitioner's office in a rural area. So this was a report the OIG issued. They're now turning to Medicaid, and Medicaid has seen a big growth in terms of reimbursement for telemedicine. And as I'll mention in a minute, Medicaid reimburses for a variety of video services, and so the OIG is concentrating on this in terms of their next review. Additional changes that are forthcoming, which will help expand reimbursement for telemedicine, are found in the Bipartisan Budget Act of 2018. So far, these have been deemed to be the most significant positive changes for the expansion of reimbursement for telemedicine today. Expands stroke telemedicine coverage beyond rural areas, which would be implemented in 2019. Expands coverage to homes and independent renal dialysis facilities. So again, we see the theme of expanding what are considering to be, proper originating sites. Interesting, providers can provide free at-home telehealth technology equipment to dialysis patients if certain conditions are met. While the Act introduces that, we always want to think about kickback issues, patient inducement, but that's an overall issue. It eliminates rural restrictions and adds patients' homes as a qualifying originating site for certain accountable care organizations. Now, and forgive me, I'm going fast, but I do know you guys want to get to lunch here. So under Medicaid, there's increased use and increased reimbursement. Currently, 48 state Medicaid programs offer some type of coverage for telehealth services. The most common type of coverage is for synchronous, video interactive. Michigan is one of those. You do provide coverage for synchronous telemedicine. 15 state Medicaid programs offer coverage for asynchronous, store and forward. You are not one of them. Michigan does not allow for that. 28 state programs offer coverage of remote patient monitoring. 42 provide coverage without geographic restrictions. As Brad had mentioned, Michigan law currently does not address the geographic restrictions or the coverage of remote patient monitoring. You're silent on that. And then most of the 23 programs set forth a list of certain sites that can serve as an originating site. And Michigan does list out specific sites, and I've got a slide later on that actually shows what those are. There is, and I'll switch back to Michigan Medicaid too. I'm kind of jumping around here a little bit, but I want to make sure I cover some of this. There is telehealth insurance coverage, and what this slide shows is we asked, respondents in the Foley survey to say, what do you see in terms of coverage, for your insurance? And this shows that, mental health services are covered, about 49%, or excuse me, 45 saw coverage, going down to telestroke. Michigan law, MCL 500-3476 for if you want the site, does provide that contracts, which includes dental care corporations, shall not require face-to-face contact between a professional and a patient for services that are appropriately provided through telemedicine as determined by the insurer. So telemedicine services are covered and should be, and they're subject to all the terms of the contract. This is providing you with samples of some of the CTP codes for non-face-to-face services. There are a number of hot compliance issues that are coming up and that the OIG and regulatory agencies are focusing on. I'm not going to go into detail on this because of time and because later on you have the pleasure of listening to my colleague Larry, Vernelli, and Jennifer, who are going to actually speak about compliance issues and regulatory considerations. But when you're developing your program, you need to think about some of these compliance issues, including reassignment. Overseas providers. I mean, generally Medicare does not cover services provided by outside the United States. Telehealth versus non-face-to-face services. As we've mentioned, Medicare does not currently reimburse for asynchronous store and forward services. The provider needs to provide the services via live interactive video consults. Compliance issues can arise with that. Incident to billing is something that's looked at. CMS is very, they've come out and said what they consider in terms of meeting the direct supervision requirement. A physician who's on the phone and another physician who's somewhere in the facility doesn't meet the direct supervision requirement. People are looking at the use of telemedicine for, meeting that incident to. Things to think about when you're looking at the program. Michigan Medicaid, as Brad mentioned, Michigan has a definition for telemedicine. Your Medicaid program has its own definition, and it actually has two. It has a general definition which defines telemedicine as the use of telecommunication technology to connect a patient with a healthcare professional in a different location. You also have a specific definition for speech language and audiology services, behavioral health, and medication therapy management. And I'm not going to read the entire definition for you, it's there. But the key of that definition is, again, it distinguishes that is not considered telemedicine if it's provided through asynchronous means. You can't use store and forward. So this very quickly is a general high-level overview of the legal Michigan telemedicine world. You have parity laws, which allow coverage of telemedicine under private insurance and under Medicaid. You do have in the regulations specialties that are actually listed out that are covered. You have listed out eligible healthcare providers. And if anybody would like a listing or the sites where all the laws are, come see me. I'd be happy to provide that to you. I didn't want to put everything on the screen or bore you. Reimbursement, as we've hammered, is that, hammered into is only currently allowed for synchronous, for the provision of services via synchronous modalities. Typically, your reimbursement rates are equivalent to in-person exams. You don't currently have cross-state licensure. Any physician providing services needs to be licensed in the state of Michigan if the patient is located in Michigan. Hopefully, you become part of the compact. That would be a wonderful thing for you. You need to have informed consent. It can be verbal, visual, or written. As an attorney, we always recommend documented informed consent. I've actually received a lot of questions regarding consent, which surprises me. If it's something where you need to consent the patient every single time they come into an office or receive services via telemedicine, if you can do it once. Generally, what we're seeing is a normal course of practice is you do it the first time the patient comes in and you're providing services via telemedicine. However, if the means or the modality of how you're providing the services changes, reconsent the patient at that time to include that specific modality. That seems to be a best practice. And then there's prescription rules. E-prescriptions are allowed, but you need to make sure that the patient-provider relationship has been established. As I mentioned, this provides you with some of the listings in terms of the services that are covered by Medicaid, the modality, whether it can be store and forward, remote patient monitoring. As I had mentioned, there's certain, things are not referenced in your law, such as remote patient monitoring. Again, the main concept in terms of Medicaid reimbursement or Michigan is it's still for synchronous only. Now, I'd be remiss if I didn't, we're talking about licensure, we're talking about regulation, reimbursement. Brad mentioned a bunch of laws. When you're developing your telemedicine program and you're looking to implement service, you have to consider all the laws, the entire regulatory landscape, which can be completely overwhelming. But you need to think about the federal anti-kickback statute, any applicable state anti-kickback statutes, Stark, FDA regulations. Consider from a technology standpoint, software can be and often is regulated as a medical device by the FDA. Think about DEA when it comes to controlled substances and prescribing. Self-referral laws at the state level, fee-splitting laws. In Illinois, we have a fee-splitting law which prohibits physicians from actually dividing or splitting any of the professional component of their services. And then if you're looking at cross, U.S. borders, you have all the international considerations. Foremost in everybody's mind right now, of course, is GDPR. Stateside consider HIPAA, state privacy laws. So there's ways to do it. And just as an overall, from an entrepreneurial standpoint, as this is being adopted, it's important to do. Patients want this. It improves quality of care. It improves access to care. But you want to do it in the right way. Take the time to plan out a strategy. Think about where are their needs? Where can I do something in a legally compliant manner? Do your due diligence. Don't jump on board just because the Joneses are doing something and you think that that means it's okay. If my neighbor said, well, they're doing this, so they must have vetted it. It must be legally compliant. It might not be. And the odds are a lot of these people honestly have been like cowboys just going out there doing it. They're rolling the dice and hoping they're not going to get caught. Vet your program. Make sure you understand the regulatory landscape. Look at costs and budgets. Associated with telemedicine is technology. Determine, are you going to need to invest in technology? Is it going to be, something that you can maintain? There's training costs associated, not only for training your providers for how to use the new technology, but also of your patients. Are you going to put like kiosk in a prison or a school or an employer facility? Are you going to have staff there to man the kiosks and help provide these services? Are you going to train someone to do that? There's costs associated with it. So to implement one of these programs, it takes a lot of planning, but the ROI in the end can be phenomenal from a patient care standpoint and from an operational standpoint. I mean, in a nutshell, your program, it can be meaningful, it needs to be clinically appropriate for what you have the capability to deliver, compliant and stable. If you follow that simple guideline, you can find yourself with a very successful telemedicine program. So with that, I know we are over time, and I do apologize for that, but I'm welcome to, I will stay back here and answer any questions if anybody wants to find me afterwards. But other than that, I know there's a wonderful luncheon and discussion waiting for all of you. So thank you so much for your time. I appreciate it.